This lecture will cover the skeletal system, which can be found in the Human Body in Health and Disease textbook by Patton and Thibodeau. The average person takes between 1 and 3 million steps per year. As babies, we're born with approximately 300 bones, and some of those bones fuse together, and as adults, we have approximately 206 bones. So what is a bone? Well, a bone, as we've discussed previously, is living tissue, and it's composed of densely packed collagen bundles encrusted with mineral crystals that contain calcium. Bone cells are referred to as osteocytes, and there are two types: osteoblasts, which build bone, and osteoclasts, which break bone down. Now, bones also provide a support structure for our body. There are firm attachments between bones and muscles, and this makes movement possible. As muscles contract and shorten, they pull on bones and therefore move them. Bones also make up joints where two ends of a bone come together. So we'll talk about different types of joints in this lecture. Bones also serve as a point of attachment for muscles through tendons, and they serve to protect internal organs such as our brain, heart, lungs, kidneys, and other delicate structures of the body. Bones also serve as a source of blood cell production through a process called hematopoiesis, which happens in the bone marrow. In addition to that, they also store various minerals, the most of which is calcium, and they serve as a storage area or a storage bank for calcium, and two hormones are responsible for stimulating either the breakdown through osteoclasts or the build up of bone through osteoblasts through hormones called calcitonin and parathyroid hormone. Calcitonin, when there is a chemical sensing of calcium levels in the blood being too high, calcitonin is released, and oftentimes it is also triggered by other chemicals in the stomach, such as gastrin. And when this happens, it sends the osteoblasts a message, and these osteoblasts start building up bone to reduce calcium levels back to normal. The opposite happens if calcium levels are too low. If calcium levels in the blood are too low, then parathyroid hormone is signaled to be released, and it signals the osteoclasts, and the osteoclasts begin to break down bone, which releases calcium into the blood system. And we'll look at a visual flow chart of that coming up here in a second. And then lastly, bones are covered with a very thin tissue that's almost impossible to see, and that's called periosteum. And that periosteum is what allows for structures such as ligaments and tendons to attach to the bone. Here we're looking at a chart that gives a good visual breakdown of what the bone is composed of, and you'll see that 44% of the bone is composed of oxygen. Does that surprise you? Did you think it was calcium? 22.2% of the bone is composed of calcium, and 15% carbon. That's why we can do carbon dating. And then phosphorus, 10.2%. And then there's some other smaller components. Magnesium, sodium, hydrogen, and nitrogen make up about less than 10% of the bone. Here's that flow chart that I promised that we would look at about what happens when calcium is too high or too low in the blood. And so this flow chart starts right here. All right, we're going to start right here. And here we're talking about maintaining homeostasis. And there's two things that can happen, right? There's the one stimulus here where calcium rises, or there's the one stimulus here where calcium falls below normal levels. So first we'll talk about raising calcium levels in the blood. So what happens, as I said before, is as calcium level rises, then the thyroid gland is stimulated to release calcitonin, and calcitonin tells the osteoblasts to start building bone, which is going to reduce the levels of calcium in the blood. Conversely, if we talk about calcium levels falling in the blood, then the thyroid gland, the parathyroid gland, is going to be stimulated to release parathyroid hormone, and that is going to do one of two things. Either it's going to stimulate osteoclasts to start breaking down bone, and or it's going to stimulate calcium uptake in the kidneys. So it's going to tell the kidneys, hold on to calcium, don't excrete it in the urine. All right. And then there's also going to be some uptake of calcium in the intestines as a result. The body is going to start holding on to as much calcium as possible. And then that's going to cause the levels in the blood to rise until homeostasis is maintained or achieved. So now we're going to cover periosteum and bone marrow in a little bit more detail. So periosteum, as I said, is this very thin collagenous covering that every bone has, and it serves as an anchor for attachment of ligaments and tendons. It's also like the skin for our bones in that it helps with defense against infection. There is also, periosteum is on the outside of the bone, but a lot of our bones have canals down them called medullary canals, which is kind of a hollowed tube, and that is lined with endosteum. Now let's talk about the bone marrow. Bone marrow is a semi-solid substance, and it is typically found within cancellous bones. Remember, we said cancellous bone is that bone that looks like a sponge, and it's usually found at the ends of long bones like humerus, radius, ulna, femur, tibia. Okay, so bone marrow helps with the production of blood cells, as we said, red blood cells and white blood cells and platelets. Now, this process of making red blood cells and white blood cells and platelets is referred to as hematopoiesis. And there's two types of bone marrow. There's red and there's yellow. And when we're growing from an infant into childhood, the red bone marrow is really active, and it is helping with the growth process by continuing to make new blood cells and platelets. And this is referred to as myeloid tissue. Now, there's also yellow bone marrow, and yellow bone marrow is responsible for making some of the white blood cells. And as we age, most of the red bone marrow goes dormant and becomes yellow bone marrow until there is a crisis, and then it has the ability to revert back to red bone marrow to help achieve homeostasis and resolve the crisis. So like I said, bone marrow is predominantly located in the ends of long bones where that cancellous bone is. It is also in some of our flat bones like our sternum, skull, ribs, vertebrae, and scapula. Here we're looking at the head of the femur that has been transected from the neck of the femur, and we're looking at that cut edge. So the opposite of the backside of the moon, if you will, that we're not seeing is the surface that would articulate with the pelvis or the acetabulum, that indent that helps to make up our hip. So you can see that I've labeled some of these areas, some of these anatomy of this head of the femur, and top left we are looking at the periosteum. So this thin tissue that you can kind of see that I'm circling, it kind of goes all the way around, but it's really visible here, is that really thin covering called the periosteum that covers the bones. At top right over here, we're looking at bone marrow. You can see that this looks very spongy. There's all of these little spaces. So this would be cancellous bone. And then the next one, bottom right, is pointing to some yellow bone marrow. You can see it there. It has a real yellowish look to it. Also, bones serve to store fat as well, so some of that is mixed in with there. And then the bottom left, you can clearly see this very compact bone, right? We said compact bone is also referred to as cortical bone. It's like the hard shell or covering. It's like the candy shell. Here we're looking at the knee joint. We're going to talk about the anatomy of this knee joint. Now, remember, big joints like hips and knees, any large joint that has bursa and synovial membranes that produce that synovial fluid that we talked about in a previous lecture are called synovial joints. So the knee is an example of a synovial joint. And we're going to start up here at the top right where it says diaphysis. Remember, the diaphysis is the shaft of a long bone. And so it's pointing to this upper bone is the femur, the lower bone is the tibia. So this is the diaphysis of the femur. Next down is, you can see here that this white line right here and this line right here, they're actually very prominent. So this tells me this might be a younger person, is called the epiphyseal plate. And the epiphyseal plate is where bones grow from. That's why we can't replace a knee when somebody is still growing. Their bones will cease to grow. So you can see that right here along the epiphyseal plate of the femur, there's a fracture. Now that's the worst place to obtain a fracture as a young person because this could potentially inhibit the growth of the bone. Moving down, again, the ends of the bones are called the epiphysis. So the shaft is referred to as the diaphysis and the end is referred to as the epiphysis. And this little space right here is the knee joint as we continue moving downward distally. And this is where that very collagenous, fibrous tissue called meniscus is going to be located. It's that cushion between femur and tibia. And then continuing our distal journey, again, the epiphyseal plate that I pointed out and the tibia. And this, we're kind of coming into the shaft of the tibia, and then lateral to the tibia. The tibia is medial in the lower portion of the leg, and the fibula is lateral. So now we're going to talk a little bit more about osteocytes and chondrocytes. Osteocytes, remember, are what we call bone cells. So they store calcium. Then there are two different types, ones that form bone, which are osteoblasts, and ones that break bone down, which are called osteoclasts. Okay, now bones have something called Haversian canals or Haversian systems. They're also referred to as osteons. And these osteons are the structural units of the bone. They're like these little circular or tube-like structures that are composed of a calcified matrix, and they're arranged in multiple layers that look like rings of an onion, or as I mentioned before, rings of a tree. And each ring is called a concentric laminella. And this is where the vessels and the nerves traverse the bone and nourish it so that it can remain alive and healthy. We also discussed previously that there are two types of bone, cortical bone and hard dense bone. Cortical bone, which is hard dense bone, and cancellous, which is that spongy bone that's located at the ends of the bone. Now, located within the little tiny compact spaces of the cortical bone are something called lacunae. Chondrocytes, we've talked about cartilage tissue before, and that cartilage is made up of chondrocytes, and it's a collagenous material that forms three different types of cartilage: elastic, hyaline, and fibrous. And these chondrocytes are located within the lacuna, right? Now, in cartilage, the lacuna are suspended in a matrix, which are much like air bubbles in a block of Swiss cheese. There's no blood vessels in cartilage, so the nutrients has to diffuse through the matrix of the cells. And because of this lack of blood flow, it makes it a little more difficult for the body to reproduce or regenerate cartilage after an injury. Here's a close-up of the differences between cancellous and cortical bone. Again, cancellous looks like a sponge, where cortical looks like a hard, compact shell. And these little kind of spongy type arrangements are referred to as trabeculae. I put this image in here because it gives us a visual idea of the anatomy of a bone. And you can see these Haversian systems over here. They look like these little concentric rings. They're kind of telescoping. Remember, this is where the blood vessels live. And also shows the periosteum. These kind of deeper down, it shows the Haversian canals and what those look like, the endosteum inside the spongy bone of those trabeculae that make up the spongy bone. As I mentioned previously, sometimes when we are fixing bones or performing various types of surgeries like spinal fusions, we need some sort of bone graft. And so I put some pictures here so you can see what they look like. This top left one is just a wedge of bone, and then the bottom one, some crouton size and some other various sizes. Bone also comes in a kind of a shaved-like substance. It almost looks like Parmesan cheese. And then on the bottom also comes in a putty that's actually loaded in a syringe that surgeons can insert into little spaces where there's bone deficit. As the surg tech, we'll definitely be handling these and preparing these. Like I said, a lot of times they like to use a syringe and take up some of the patient's blood, and then they can mix it with the bone graft. But this is very expensive, and as we're handling it, we want to be very careful that we don't drop it or contaminate it or anything like that. So let's talk a little bit more about bone growth. Bone starts to form within the first few weeks of the fetus's life. And typically the process is bone is moving from a type of cartilaginous tissue. Remember, we said that there are chondrocytes, and chondrocytes are cartilage cells that fill the lacuna, right? And so bones start as cartilage, and then as the fetus develops, they begin to harden. So there's two processes. So the first type is the intramembranous types of bones, and these are typically flat bones. Now these bones begin as kind of a fibrous membrane, and remember when I said at the beginning of the lecture that a baby is born with about 300 bones, but once we become adults we have about 206. And this is why these bones will eventually fuse together. Some of them, when the baby is born, like the skull bones, they're not fused yet because the brain is still growing and the skull needs to expand to accommodate that. So they usually start as a membrane, such as skull bones, flat bones, and then they develop into bones and they fuse over time. Now, endochondral bones are typically our long bones that begin as cartilage, and they start to harden from the center towards the ends. And you can see I love this picture here because you can see right here, I'm circling in purple, this is the femur or the thigh bone, and you can see how the ends look a lot more vascular than the center does. And that's because this ossification process starts at the center and then works its way out towards the epiphyseal plates we talked about before. And then again, just another shout out that there's two different types of osteocytes. Osteoblasts, which build bone. I remember blast and build. And then osteoclasts are the constant remodeling of bone. They break it down so that it can be rebuilt. So just like our skin, how it's it's always regenerating itself, bones are constantly regenerating themselves as well. As discussed previously, the skeleton is composed of approximately 206 bones. 106 of those which are in the hands and feet alone. So the skeleton is divided up into two primary sections. The first one is the axial skeleton, and the axial skeleton in this image you can see is kind of an orangey pink color, and that is basically the trunk of the body. So the head, the torso, and the spine and the sternum. The appendicular section, or appendages, I like to think of, because it helps me to remember that the appendicular skeleton is primarily composed of the extremities and the pelvis. Bones are classified or grouped together by their shape, and there are 5 classifications of bones, including long bones, short bones, flat bones, irregular bones, and sesamoid bones. So we're going to take a look at each of those on the upcoming slides. So let's take a look at some different types of bones. The first we're going to look at are short bones. And short bones are the carpals, which are the bones of the wrist, the tarsals, which are the bones of the ankle, and these bones typically occur in clusters. Flat bones are our ribs, scapula, sternum, and cranial bones. And irregular bones are facial bones and our cranial bones that are deep within the skull, and also our vertebrae. And lastly, sesamoid bones are bones that are found within tendons, and they don't typically make up joints. So 2 examples are the patella, which is found within the patellar tendon, and the sesamoid bones of the foot, which it comprises the ball of the foot. Here we're looking at the bones of the skull, and we can see here flat bones and irregular bones. So as we're kind of looking at the skull here, these bones that we can see, the frontal, parietal, occipital, and temporal bones are all considered flat bones. And the ones on the right side are considered irregular bones. So those would be bones like the sphenoid, the vomer, the maxilla, the palatine, the mandible. And then this bone is really interesting right here and really special, the hyoid bone. The hyoid bone is the only bone in the human body that is not adjacent to another bone. It's a free floating bone. Here's another view of the skull, and you can see that this is an infant skull and the different suture lines. So here's the coronal suture line. This one, lambdoidal. There's also the sphenoidal fontanelle, and you can see how in this top view here that's at the bottom of this image, where the frontal, parietal, and occipital bones are not touching. They are not fused. These are those intramembranous bones that we talked about previously and fuse later in life to allow for the growth of the brain. Now, sometimes these bones fuse prematurely, and this is referred to as craniosynostosis. And if a baby is born with craniosynostosis, then a surgery is performed where they actually make cuts into the bone and put in these little spacers, and the babies get to wear these really cool looking helmets, and then that allows for the continued development of the brain. Here we're looking at the spine, and there are three main segments of the spine, and then the sacrum and the coccyx are five fused bones that make up the tail. So the first part of the spine is called the cervical spine, and the cervical spine is consistent of 7 vertebrae. Then the next section is the thoracic vertebrae, and the thoracic vertebrae are composed of 12, that's not that great of a 2, I apologize, 12 thoracic vertebrae, and the lumbar section is composed of 5 vertebrae. So the way that I remember this is we have breakfast at 7, lunch at noon, and dinner at 5. And then the sacrum is 5 fused little segments like I talked about before. Now, just as there are a variety of sections of the spine, there's also anatomy of each one of those little irregular bones that we refer to as vertebrae, and they have various processes that come off from the vertebral body. And in between, we're going over here to the left now, in between the vertebral bodies are the vertebral discs. And when we talked about cartilage in a previous lecture, this is that very fibrous, very inflexible type of cartilage. So there are several things that can go wrong with the spine, and if you look at the top image, if you can tear your eyes away from the image on the left and look up for a second at the top image, these are some different irregular curvatures of the spine, and the first one is scoliosis. Now this is a lateral curvature of the spine. That next one there is called kyphosis, and kyphosis is also, the street term is a hunchback. So the hunchback of Notre Dame, he had kyphosis. All right, and then lastly is lordosis, and lordosis is the abnormal anterior curvature of the lumbar spine. And sometimes in surgery, we do spinal fusions, and we use these rods and pedicle screws that you can see here on this bottom left image, and then the radiographic image of it you can see there on the right. And if anybody can tell me when we meet the next time what these little structures are showing up on the image, I will give you a free late pass. Here we're looking at the ribs. The average person has 12 pairs of ribs. However, 1% of the population have 13 pairs of ribs instead of 12. So in an average person, the first 7 ribs are considered true ribs. And the reason they're considered true ribs is because they attach directly to the sternum. Can you see how they attach directly there? Right, and then the next 3 pairs of ribs are referred to as the false ribs, and that's these guys right here. All right, and you can see how they don't attach directly to the sternum, but attach to this cartilaginous area, and then are attached to the sternum that way. And then the last 2, let me see if I can make it 2. The last 2 ribs are considered floating ribs, and the reason they're considered floating ribs is you can see the little edges of them right here, that they're just kind of floating there and they do not attach to the sternum at all. Here we're looking at the bones of the upper extremity. So this is going to include the upper and lower arm, and then also the shoulder girdle. So you can see if we start at the top, the clavicle here, The clavicle attaches to what's called the acromion of the scapula, or the shoulder blade. They form a joint there called the acromioclavicular joint. And when individuals come in for surgery, sometimes they're having impingement syndrome in their shoulder joint, and that's where this is occurring, at that acromioclavicular joint. And then as we're moving distally, the humerus and the fossa of the scapula, they make up the shoulder joint, and the head of the humerus fits into that little depression of the scapula called the glenoid cavity. Now this is just kind of a free floating joint. It's not the same as the hip joint, where the head of the humerus just kind of sits into the glenoid, and that's why we need the rotator cuff to hold that joint into place. Now, we talked about the humerus. Remember the shaft of the bone? Do you remember what it's called? The diaphysis. And then the end of the bone, do you remember what that's called? That's the epiphysis. And the distal portion of the humerus then makes up the elbow joint with the radius and the ulna, the radius being thumb side, the ulna being pinky side. I remember this by, if I'm hitchhiking with my thumb up, the rays of the sun touch my radius. There are other ways to remember it as well, of course. So these various indentations are called fossas, where the heads of bones meet with an indentation in another bone to make a joint. There are also different processes. We don't need to know all of those. It's just nice to know that these processes are where ligaments and tendons can attach, so they're points of attachment, and they're also really good for landmarks as well. And then as we continue moving distally, we have the, that's a really bad circle, I apologize. We have the bones of the wrist, which are called the carpals, and the bones of the hand are referred to as the metacarpals, and the bones of the fingers are referred to as the phalanges, which is the same as the toes. We refer to the toes as phalanges as well. So here we're looking at the carpal bones, and there are 8 carpal bones, and these are those short bones that are typically grouped into clusters, like we said before. And down below are some acronymic sentences that could help you remember what these names of these carpal bones are. I would highly suggest using the Wiley anatomy drill activities that are located in the course. This will help you with your gross anatomy. There's also another really good PowerPoint resource there for the overview of anatomy as well. Okay, here we're looking at the pelvis and the femurs, the proximal ends of the femurs. So we can see here how the sacrum fits in with the ilium and ischium of these wings of the pelvis, okay? And then the that fossa that I talked about here, where the heads of the femurs fit, that's called the acetabulum. Here we're looking at the lower extremity, and again, you can see how the head of the femur is situated into this acetabulum. Now there's, this is a really good fit inside here. Dissimilar to the shoulder joint, the head of the femur actually kind of snaps into the acetabulum, but there is a little ligament that is attached from the head of the femur into the acetabulum that also helps to keep it in place. Another landmark that we use a lot of times in surgery is this little area that I circled right here that's called the greater trochanter. Moving distally, we can see how the distal femur and the proximal tibia, they comprise the knee joint. And then this little button right here is the kneecap or the patella. Moving distally still, we can see how the tibia makes up the medial portion of the distal portion of the limb. And then the fibula is lateral. Here are our ankle bones right here. These are referred to as the tarsals. And again, we have these little bones of the foot called the metatarsals. There are 5 of those, and the phalanges. Here's a good look at the bones of the ankle and the foot. And again, a mnemonic that might help you to remember what those bones are, as well as some acronymic sentences. So where 2 bones meet, they form something called a joint. And we're going to talk about the different types and then also some terms associated with joints. So different types of joints, there's 3 different classifications, and we're going to look at an example of all of these. The first type is called a synarthrotic joint. And a synarthrotic joint, if you remember from medical terminology, SYN refers to something that does not, something without. So a synarthrotic joint means a joint without movement. An amphiarthrotic joint is a joint that is slightly movable, and then a diarthrotic joint is a joint that is freely movable. And I have some examples listed here, and we're going to look at all of those in a second. Now, some terms that you need to be familiar with. The first one is articulation, and where 2 bones come together to form a joint, we say that that's where they articulate, or that's their articulation point. So the head of the femur articulates with the acetabulum, and these joints are classified, like I said, according to types, and those types are grouped into how they move. So again, semiarthrosis means immovable, amphiarthrosis means slightly movable, and diarthrosis means freely movable. So the best example of synarthrotic joints, which are joints that are immovable and in close contact with one another, but are still separated by a thin layer of cartilage, are our skull bones. So here you can see the skull bones, and remember in the fetus, this looked a little bit differently with these big spaces, kind of membranes just joining these kind of separate bones, and then after the growth period, these bones fuse, and these edges where they fuse, those are called sutures. So you can see here the coronal suture. Remember, we talked about the coronal plane. Again, this is where that comes from, that coronal plane going from ear to ear across the top of the skull. And then you can see the sagittal suture. Remember the sagittal plane, and this will make sense. And then the lambdoid suture in the back between parietal and occipital bones. As I said previously, amphiarthrotic joints are slightly movable and separated by a disc of cartilage, and that movement is limited to the flexibility of that cartilage. So, can you think of an example? If you thought of the vertebral bones or the bones of the pelvic girdle, you are exactly right. The movement of these bones, remember, is limited by the flexibility of the cartilage. And between our vertebrae, we have this slightly flexible fibrocartilage that serves as a cushion between the 2 vertebrae. However, as we age, this material can become even less flexible, which can impede movement. So here we're going to talk about diarthrotic joints and some different types. So the first type that we're going to talk about is the ball and socket joint. The ball and socket joint is the most freely movable joint that can move in every single plane. They are considered synovial joints. Remember, they have synovial membranes lining bursa that produce lubrication for the joint. They have a ball-shaped head and a cup-shaped socket. Can you think of an example? If you thought of the hip joint or the shoulder joint, you would be exactly Correct. Another diarthrotic joint is the condyloid joint. So the condyloid joint has movement in one plane and a little bit of lateral movement, and they have something called a condyle and a fossa. So a condyle is a protrusion or a little bump, and a fossa is an indent. Can you think of an example? If you thought of the mandible and the maxilla, how they work together, that would be an example of a condyloid joint. You can open and close your mouth in one plane, but you also get a little bit of side movement with the jaw as well. And then another example is where the metacarpals of the hand join with the phalanges. We get that up and down hinge movement and also a tiny bit of side to side movement. And you can see here, this is a really good example up here of a condyloid, a condyle, a little process, and then this condyle of the maxilla fits into this little fossa. And then you can see the same here, the metacarpal, the head of the metacarpal, how it's more rounded, and then the phalange or the phalanx has like a little cup. The next type of diarthrotic joint that we're going to talk about is the gliding joint. Gliding joints have side-to-side or twisting motion and surfaces that are either flat or curved. Some examples of this are the carpals and the tarsals, how they slide against one another and have slightly concave and convex surfaces. Now the hinge joint allows for movement in one plane only, and again, it's composed of a concave surface and a convex surface. So when I think hinge joint, I think of like a hinge on a door. A door swings open and closed, similar to how our elbow or our knee can move, extend, and flex in one plane. Next, we're going to talk about a diarthrotic joint called the pivot joint. The pivot joint has rotational movement, which allows for pronation and supination. Can you think of an example here? If you thought of how the radius and ulna rotate around each other to allow us to turn our palm down or our palm up, you would be absolutely correct. This is an example of a pivot joint because the two bones rotate around each other in a little notch that creates a pivot joint. The last type of diarthrotic joint we're going to talk about is the saddle joint. The saddle joint allows movements in a variety of planes, contains concave and convex regions where one surface fits snugly into the other surface. Can you think of an example? I'll give you a hint. This separates us from most other animals on the planet. Did you guess the joint between the bone of the wrist and the first metacarpal of the thumb? Then you would be absolutely correct. This is an example of a saddle joint, and this is what gives us the opposable thumb. All right, I'm going to encourage all of you to get up on your feet and practice some joint movement hokey pokey. Are you guys ready? Are you on your feet? We're going to start with abduction. All right, if you bring your arms out to your side, that's abduction. Now bring them back to your body. That's adduction. Let's practice them together. Abduct and adduct. Abduct and adduct. All right, now let's practice circumduction. Keep your arms out to your side and move your arm around in a big circle. Do it again. Great job. Now let's try rotation. Move your head in a no-shaped motion from side to side, to the right and to the left, and to the right and to the left. Good job. Now let's practice dorsiflexion and plantar flexion. To dorsiflex, we pull our toes up to our shin. And to plantar flex, we point our toe. Are you ready? Let's start with the right. And dorsiflex and plantar flex. And dorsiflex and plantar flex. Now let's try with the left. Are you ready? Dorsiflex and plantar flex. Dorsiflex and plantar flex. All right, are you ready for eversion and inversion? We're gonna use our feet again. To evert, you turn your foot out, and to invert, you pull your foot into the middle. Are you ready? Let's start with our right. Evert and invert. Evert and invert. Now let's switch sides to our left. Ready? Evert, invert. Evert, invert. Evert, invert. Great job. Now let's practice flexion. Put your arms back out to your sides again. We're gonna flex in our arm at the elbow, and then we're gonna extend it out. Are you ready? Let's start. Both arms at the same time. And flex and extend. And flex and extend. All right, last but not least, back to the arms, both of them straight out in front of you, palms down. This is pronation. Supinate, turning the palms up to the ceiling. Let's practice that. Pronate and supinate. Pronate and supinate. Great job. You just did the joint movement hokey pokey. Give yourselves a pat on the back. Would that be flexion? All right, I hope you all have had a chance to catch your breath. Now we're going to talk about some factors affecting bone growth. There are several factors that do affect bone growth. On the right here, you can see two images, the top one being what normal cancellous trabeculi look like, and the bottom what an osteoporotic bone might look like. Some factors we're going to talk about are hormones, heredity, nutrition, and exercise. So first and foremost, hormones. Hormones maintain peak bone mineral mass. Now, the scary part of that is in females, there's a high incidence of osteoporosis. And this is because as the female ages and goes through the menopause process, those hormones begin to recede. And because of that, there is an increased risk of osteoporosis. Heredity is another factor that can affect bone growth, and this stems from genetics. Nutrition is also a factor to consider, that we get our nutrients from our food, and adequate levels of vitamin D help us to increase the uptake of important minerals such as calcium. And then lastly, exercise. Very important that we get the weight-bearing exercise that we need to maintain bone strength, because that's, even if it's a slight impact like walking helps to maintain the strength of bones. So exercise is also a factor. Here's a little overview of osteoporosis, also referred to as the silent disease, which I said is very common in women, 4 times more common in women than men. Only 1 in 12 men are affected by osteoporosis. And the thought is the more estrogen, the higher the bone density, and the reverse would be true. Lower estrogen levels decrease the density of the bone, which increases weakness of the bone. In situations where we have elderly individuals that fracture their hips, statistics show that 25% of them will die within 1 year of that hip fracture. And this is because it becomes more difficult for them to ambulate and to get around. And typically they develop pneumonia because of it. the most common fractures associated with osteoporosis are of the hip, spine, and wrist. And at least 40 million individuals are affected in the US. Now, these did come from a study in 2007, so they're a little bit aged. Risk factors, again, low hormone levels such as estrogen. White and Asian populations are affected most, and of course females, like I mentioned before. Some other situations such as body size, age, anorexia, which malnutrition becomes the factor there, various types of medications, the amount of exercise that one gets, and smoking and drinking can also contribute to poor bone health. Now let's take a look at some other skeletal disorders. The first one we're going to take a look at is osteosarcoma. Remember when we talked about tissues and there was a shout out, or disease mechanisms, I guess, there was a shout out to cancer. So a malignant type of bone cancer is referred to as an osteosarcoma, and you can see that in the top image. There can also be chondrosarcomas. Both of these occur in or arise from connective tissue, osteosarcoma arising from bone, and chondrosarcoma arising from cartilage that lives within the lacuna of the bone. Osteomyelitis is an infection of the bone, and it is typically caused by Staphylococcus bacteria, our friend Staphylococcus. The treatment is typically parenteral antibiotics or IV antibiotics. Rickets is characterized by a vitamin D deficiency. Vitamin D, remember, helps the intestine to absorb nutrients, and bones need calcium to remain healthy and viable. So if there's a vitamin D deficiency, the intestine isn't taking up nutrients like it should, and one of those is going to be calcium. In addition to that, we need to make sure that we get enough sunlight. So a lot of us are stuck in our homes right now, and it's important that we get out and we get some exposure to the sun. And we can also get vitamin D from milk and juices and some other fruits and vegetables. Now, Paget's disease is characterized by this frenzied remodeling of the bone. So remember how we talked about bone is constantly remodeling itself. It's building up and it's breaking down. Well, this is an overdrive type of situation. And because of this, that can result in deformed bones, unstable bones, and also bones that can become fractured very easily. And it's also referred to as osteitis deformans. And then the last one is brittle bone disease or osteogenesis imperfecta. Now, osteogenesis imperfecta is a genetic disease that is found in about 1 out of 30,000 births, and it's also referred to, like I said, as brittle bone disease. If you ever saw the movie Unbreakable, Mr. Glass had this osteogenesis imperfecta. So now we're going to talk about different types of fractures. And a fracture is a result of some sort of excessive mechanical stress on a bone. So there are some different types. There are complete fractures, which means it's completely broken all the way through. Incomplete, which means it could just have like a partial break. And then there is a term that we use for an incomplete dislocation, which is subluxation, and then a complete luxation, which is a complete dislocation, and that is this image that you see here, this luxation of the distal humerus. So some common fractures, let's take a peek at what those look like. If you look down along the bottom, these images, you can see some of the most common ones pictured here. The first one is transverse. So if we think about the transverse plane, we know that that goes across. And so that is a break that goes across the diaphysis of the bone. A linear fracture is going to go in line with the bone. It's like a vertical fracture in the shaft or the diaphysis. Oblique, just like it sounds like, is a diagonal break of the bone. And then breaks can either be non-displaced or displaced. A break that is displaced means that it is completely disconnected and it is no longer in alignment, whereas non-displaced means that it's broken, but it's still in alignment. So there can also be an oblique displaced fracture. A spiral fracture is caused by some sort of twisting force or torque on the bone that causes the break. And then green stick fractures typically occur in children, and it's kind of like if you take a green limb off from a tree and you try to break it, more than likely instead of snapping, it's going to bend, and so that green stick fracture gets its name from that. And then the last example here is comminuted, and comminuted means it's broken and then it's crushed. So there's several little pieces, fragments of bone that most of the time are impossible for us to be able to put back together. Here we're looking at some different hardware that we would use to fix a fracture. So you can see that there's different types of plates, and they have different numbers of holes and they have different shapes depending on what bone we're fixing and how long or how big the fracture is, those kinds of things. And then down in this bottom corner, we'll put an X in this box right here. These are those rods that are used to go down the medullary canal. So I think before I had mentioned intramedullary rods or nails. And so this is what those nails look like that would be put down the shaft, the medullary canal of the shaft of the bone. And then one last one I just want to point out right here. These are the hardware that we would use for a spinal fusion. So these are the rods and the pedicle devices that we would use to do a spinal fusion. And then one last one I want to talk about is these up here. Now there's different types of screws that we use, but these are special. They're called cannulated screws. So cannulated meaning we can put this wire into a bone to stabilize it, and then we can drill over the top of it with a drill that kind of looks like a straw. We'll go over the wire and drill over the wire so we can keep the bone held in place, and then the screw goes over the top of that, and then once we get our fixation we can remove those wires. So not all screws are like that. Some are solid, but then some are cannulated. So there's two types of fixation that we typically use, internal and external. And if we're doing internal fixation, we typically call this an ORIF, which in medical terminology you should have learned stands for open reduction internal fixation. So we're going to make an incision, we're going to reduce the bone, get it in alignment, and then we're going to put in some sort of plates, screws, or whatever. And then the other type would be a closed reduction, where they can kind of manipulate the bones through the skin and then put in some type of wire, or this top picture on the right here. This is referred to as an external fixator, and the external fixator is commonly used on the wrist. On wrist fractures, the bones are in place, so they are in alignment, but we can achieve stabilization of the wrist by using this external fixator, where two screws go in the metacarpal of the hand, and two screws go into the radius here, and then this device fits onto those screws and tightens down so that it eliminates the movement and stabilizes the fracture. Here's a little glimpse of what a setup for a total knee procedure would look like. You can see the surge tech is here at the forefront facing us, and these are all the specialty trays that we would use. And then the other little table that's to the side or to our left is where the general instrumentation would go. So with total hips and total knees, there's a lot of trays and a lot of instrumentations. The surge tech is assembling a lot of components and disassembling a lot of components. And typically in these situations, there is a device rep that comes to guide the surge tech through the different steps. In orthopedic surgery, radiography is pretty much a staple, and there's a couple different types. There is fluoroscopy, which is representative of this machine that you can see on the left of the screen. This is a mini C-arm, and the C-arm is a device where we can look at a bone in real time. So it's almost like we can take a video of the bone. We could also take still images as well. And then on the other side is just the regular flat plate still image that we could traditionally take. This one is a mobile unit, so they can bring it right into the operating room to take an image. And you'll learn more about that in your surge tech classes. So let's talk a little bit about bone healing, because when we have a patient that has a fracture, our concern is that it's going to heal adequately and correctly. And so under perfect conditions, we should see healing in about 8 to 12 weeks. How do we get this adequate healing and fixation? Is by completely immobilizing that fracture. If we don't immobilize the bones and they're allowed to continue to move, they're not going to heal. Also, proper alignment is really important, and making sure that those broken bone edges are up against one another, and that's going to promote healing. So the process of healing involves a few steps, and the first step is inflammation. So after a fracture, bleeding and inflammation develop in the affected area. And we talked a little bit about inflammation and that process of vasodilation and products being able to move to the site of the crisis more quickly. The next stage is referred to as proliferation, and proliferation is where this kind of clot is developing, and that's going to take a couple days, a couple day process. And then next, we're going to get this bony framework that is forming called a callus. Now, this is going to help to stabilize the bone during its reparative process, and this lasts about 3 to 4 weeks. Next, we're going to see ossification start to occur, and this begins about week 2 or 3. And remember, our osteoblasts and our osteoclasts, they're going to continue to remodel the bone after the fracture has actually been healed. It's going to continue to remodel and reconstruct and re-stabilize that fracture. And there it is, remodeling. Remodeling is the maintenance state. So this is how proper bone healing occurs. However, if there are patients that have underlying conditions, then this could impede the healing process. So there are different types of joint disorders. Non-inflammatory, inflammatory are the two that we're going to talk about. So non-inflammatory joint disease, an example is osteoarthritis, or you might hear it just called arthritis, which is degeneration of the hyaline or articular cartilage that's found at the ends of the bones where the bones articulate or where they rub together. All right, so this is going to cause painful joints. Another example of an inflammatory joint disease would be rheumatoid arthritis. Remember, rheumatoid arthritis is an autoimmune disease. So what happens in these situations is the body's immune system is attacking itself. It sees the self as an invader, all right? Another example of inflammatory joint disease is gout, or the book refers to it as gouty arthritis, which is a chronic type of joint inflammation that is a metabolic condition. And what happens is uric acid and different wastes called nitrogenous wastes increase in the blood. All right, this gets deposited as crystals in the joint spaces, and this causes pain, okay, and inflammation. And then infectious arthritis. Infectious arthritis can be caused by a variety of different pathogens, and one form is arthritis that is caused by Lyme disease. Lyme disease, you typically find this in areas of the United States where there's more of a wet type climate, so not as much here in Arizona, but in Connecticut in 1975, they identified this, and it was being transmitted by a vector called a deer tick. So we typically get it from ticks, but this can cause inflammation of the joints, which leads to arthritis. So just bringing it back to us as surge techs and how all of this applies to us, just a shout out to joint arthroplasties, right, joint replacements. Here you can see in this image a replacement of the metacarpal. So this is looks like a replacement of between the first metacarpal and the first proximal phalangeal joint here, and we use these little trials after we hollow out the shafts of the bone, and then these little trials, this little flexible rubber trial can be placed in there, put the joint through a range of motion, and then a silicone implant that looks similar to this trial will be left in the patient. And then the one on the right is a replacement of the joint of the big toe. Another common procedure in orthopedics is the arthroscopy, and an arthroscopy is using a scope to look inside a joint space, and so these are some pieces of equipment and instrumentation that would be used for arthroscopic surgery, which we'll talk about more in your surg tech classes. This is a picture of an arthroscopy of a knee. And on the left, you can see this kind of torn up tissue. That is the meniscus. Superiorly, you're seeing the femur, the distal femur, and inferiorly, that bone is the proximal tibia. And then in the other image, the same, but in between, you can see that meniscus, and they've actually put a stitch in there and repaired the meniscus. And we can do this arthroscopically. That brings us to the conclusion of our lecture on the skeletal system. I hope it was helpful and beneficial to your learning. Make sure that you identify any muddy points that you have, and I look forward to reviewing this chapter with you in class.